Welcome back to the Rebel Core Content Podcast. Core content for anyone, anywhere, and just in time. This is Swami, and I've got a solo cast today on a topic that we see fairly frequently in the emergency department, which is acute pericarditis. This is defined as inflammation of the parietal and or visceral layers of the pericardium surrounding the heart. While we generally think about infectious causes, specifically viruses causing pericarditis, there's actually a number of different causes that can be at play. You can get other infections from bacteria or fungi or even parasitic. There are toxic metabolic causes like uremia and certain medications. Systemic diseases like rheumatoid arthritis, sarcoidosis, systemic lupus erythematosus, amyloidosis, scleroderma can all manifest with pericarditis. And you can also get it post-injury after an MI, trauma, surgery, or radiation. The key in making this diagnosis is with the presentation and understanding what symptoms you're going to see. They're going to have chest pain almost all of the time, and that typically is going to be sharp and pleuritic. They can be improved with sitting or leaning forward. They can be increased with lying down, and you often see radiation of that pain to the trapezius muscle. Fever can be seen, but it's not always there. Sometimes the patients are going to have other symptoms around that viral infection, so myalgias can be there as well. And exam findings are kind of limited. We're taught about pericardial friction rubs, but we know that these come and go, and sometimes you'll hear them and sometimes you won't. We can't really rely on that finding to make the diagnosis. Often these patients will have pericardial effusion, so that's something that we can diagnose using ultrasound. But of course, you don't have to have a pericardial effusion to have pericarditis, and not all pericardial effusions are from pericarditis. The diagnostic criteria, again, really are all clinical. You have to have 2 out of the following 4 things. 1, classic chest pain history, sharp, pleuritic, positional with radiation to the trapezius ridge. 2, a pericardial friction rub, which again, as we mentioned before, is often going to be non-present. Number 3, pericardial effusion on echocardiogram. And then number 4, the characteristic EKG findings. Technically, you can make this diagnosis based on the classic chest pain history, that sharp or pleuritic pain, along with a pericardial effusion on your echo. But I think most of us would like to see the EKG findings to really feel secure that we're working with pericarditis. Let's dive into those EKG findings. EKG is a reliable diagnostic tool. However, EKG changes occur in stages over time, and classic findings may not be present depending on the duration of the patient's symptoms. We should also caution everybody by remembering that acute ST segment elevation MI or STEMI is often misdiagnosed as pericarditis. And so the first step in diagnosing pericarditis is to think about, could this be a STEMI? There's an excellent review of the differences between those 2 in ECG Case of the Week from Alma 2. We will drop a link to that in the show notes. In STEMI, the ST segment elevations are typically convex in nature. The patients may have concomitant T wave inversions with those ST elevations. Reciprocal changes, ST depressions, are commonly seen, and repeat EKGs can show dynamic changes and development of Q waves. This is particularly important when we look at inferior and inferolateral STEMI because that can be very easily confused with pericarditis. If you see non-concave morphology of those ST elevations, that's much more typical for STEMI, and any depression in AVL is sensitive and specific for that inferior wall MI. With that as the caveat of what we should be looking for to make sure it's not a STEMI, let's talk about the changes we do see with pericarditis. Stage 1 occurs over hours to days. It's characterized by diffuse ST elevations. The morphology of those should be concave upwards. You may see some ST depressions, but only in AVR and V1, and you should not see any reciprocal ST depressions. PR segment depression can be seen. The Spodek sign can be seen. That's that down sloping of the TP segment. But again, we have to stress that you can have diffuse ST elevations, no reciprocal changes, and the only ST depressions that should be present are in AVR and V1. In stage 2 of pericarditis, ST and the PR segments start to normalize. T waves will flatten and then transition to deep symmetrical T wave inversions. And then finally, in stage 3, you get resolution. The ST and PR segment changes should be resolved. And those T wave inversions we see in stage 2, they can resolve, but they can also persist. From a laboratory study standpoint, there's really no test that is sensitive or specific to rule in or rule out pericarditis, or even to differentiate it from a myocardial infarction. Some people talk about white counts, but you can see a white count elevation with an MI, and troponins can be useful to obtain because if they're elevated and you think you have pericarditis, you got to think about myocarditis or myopericarditis. The only other diagnostic test that's really necessary is an ultrasound. You want to look and see, is there a pericardial effusion? One, because it's part of the diagnostic criteria, but you also want to make sure that the patient doesn't have a large pericardial effusion, because that in itself may be a reason to admit and watch the patient closely. In addition to that, if you're good with ultrasound, you can look for focal wall motion abnormalities, which of course will be much more commonly seen with STEMI and not pericarditis. Once you make the diagnosis, we're going to move to medical management. There's a great clinical card from Academic Life in EM. We will drop that in the show notes. A good way to remember all of the different options. In general, we're going to start with NSAIDs or aspirin. Both of these should be tapered over a 3 to 4 week course. The optimal regimen is unknown, but what I will typically see is ibuprofen 600 milligrams every 8 hours for 10 days, followed by 400 milligrams every 8 hours for 10 days, and then 200 milligrams every 8 hours for 10 days. If you're looking at aspirin as an alternate, again, we will put that in that clinical card. Colchicine has gotten a lot of play recently with some good clinical data showing a benefit of colchicine over some of our other drugs. If the patient is over 70 kilos, you start with colchicine 0.6 milligrams by mouth every 12 hours for 3 months. If they're less than 70 kilos, same dose, but you only do it once every 24 hours. There are some contraindications to colchicine. We will put those in the show notes as well. Colchicine here is going to be paired with either your NSAID or your aspirin. So NSAID or aspirin plus colchicine. And then the third part of that is giving the patient a PPI to protect them from the GI irritation that you're going to get from both of these medications. Typically, we're going to give that PPI every 24 hours for 3 months. Steroids often come up in the discussion, but steroids really don't play a role in the primary management of pericarditis. They might actually increase the risk of recurrence. So corticosteroids, typically not a first-line drug, but if the patient has one of these connective tissue disorders, they might already be on steroids. That might be something that you're going to treat the patient with. Probably do that in conjunction with a cardiologist or a rheumatologist to make that decision. Most patients with pericarditis can be treated as an outpatient as long as you have clearly established that pericarditis is what's at play. If they have myocarditis or myopericarditis, you should consider admitting them because those patients are at a higher risk for lethal dysrhythmias. Again, we can use troponins to determine whether the patient has myocarditis or myopericarditis. In addition to that, patients with large pericardial effusions should probably be considered for admission as well, to monitor them, make sure they're stable, and they may actually need to get a pericardiocentesis done. All right, let's wrap up the week with some take-home points. Number 1 is that pericarditis is a clinical diagnosis based on having 2 out of 4 diagnostic criteria. Classic chest pain, sharp, pleuritic, positional with radiation to the trapezius ridge, a pericardial friction rub, pericardial effusion on echo, and the characteristic EKG findings. Number 2, always consider STEMI as the diagnosis prior to diagnosing pericarditis. If the EKG shows convex ST elevations, reciprocal ST depressions, or dynamic changes, the patient's much more likely to have a STEMI and move away from that diagnosis of pericarditis. Number 3, patients with pericarditis should be treated with a combination of NSAID or aspirin plus colchicine plus a PPI. And then finally, patients with large pericardial effusions, tachycardia out of proportion to fever or pain, a troponin elevation, these patients are more likely to have complicated courses and should be considered for admission. That's all for the Rebel Core Content Podcast this week. We'll be back in 2 weeks for another cast. In the meantime, remember to go over to our site and check out all the fantastic posts from our team. And until next time, stay safe.